And now it is my pleasure to introduce David Higginson, Executive Vice President and Chief Administrative Officer of Phoenix Children's Hospital, to set the stage for the day. David, the podium is yours.
Thank you. Thanks. Good morning, everybody. Excuse me if I squint a little bit, the light's a bit bright there. As you see, I have a lot of titles here. The reason I leave the CIO one on there and the CAO is I can't believe they let an IT guy actually take over human resources and materials management. So what am I going to talk about today? So what I was asked to talk about is how IT is really converging with life sciences, and I've decided to kind of split it into 4 areas. One of them is efficiency, one is the patient quality, and then research, and talk a little bit about how IT is really bridging those areas and trying to help make life better. So just a little bit about me. I'm a suit. I sit a lot of time in meetings every day. I don't have any formal IT training at all. I'm actually an accountant, so that puts me in good stead for all those other jobs I was telling you about. I faint at the sight of blood, so a great place to work in a hospital. Kind of eyes straight while I'm walking down the unit hallway, don't look at anything. As you can tell, I'm not from here. I'm also not from the South. I'm from England originally, actually, but right now I don't have a green card, so I'm a little bit in limbo. So a little homeless, and for those of you that are technically bent, I still do write code every day, so I have a little bit of chop still in IT. Hopefully you know a lot about Phoenix Children's Hospital. We're about a 30-year-old hospital. For the first half of that, we were a hospital within a hospital over at Banner Good Sam. But now one of the 5 largest children's hospitals in the country with over 350 beds, and more than 15,000 annual admissions every year, 90,000 ED admissions and growing. That's in an ED that was built for 15,000 patients, so that's a little challenging, and a lot of subspecialties. So a hospital that's growing very rapidly here in the Valley. So this is what I want to start about talking straight away. So I figured the first way to try and get you interested, a little bit of bathroom humor that always kind of seems to go well. And when I deal with data, it often feels like it's diarrhea. So it's kind of simultaneous between the both of them. The story I want to tell you happened a long, long time ago, and maybe it was one of the first times when we used data to solve a problem. So back in 1854 in England, open sewers running everywhere in all the cities, cholera epidemics, people dying all over the place, and the smart people at the time thought it was the smell. They figured out the smell was the way the disease got transferred, and of course they're sitting up in Harley Street, they don't want to go down there, so they just decided if I don't smell anything, we'll be fine. There was one very smart guy, Jon Snow, who decided that couldn't really be right, and he got to try and figure out how do we use data to really figure out what this problem is. And so what he did, he created, you may have heard of this, what's called the ghost map. And he took a map of London at the time and he put a little black mark on every single place where someone had died. Now this may seem a bit morbid, but it's kind of the first recorded episode of someone using data to solve a problem. And what he figured out where that red dot is, that there was a pump that pumped water, and that may be the cause of it when he looked at the data. And so what he did was, he used a small amount of data and had a big impact, and he went right to the source of the problem. He didn't just produce a paper and say this might happen. He went to the pump, took the handle off the pump, and lo and behold, 2 weeks later, the cholera epidemic started to subside. And so what that really tells you is back even all those years ago, that data collection, aggregation, analysis, displaying it in a useful manner solved a myth and got past all that anecdotal evidence and got to save lives. So I actually was in England about 2 months ago, and there's a pub right next to the pump. And this is the classic win-win situation. You take the handle off the pump, you solve a problem, and where do people now get something to drink? They go to the pub. So if you're saved, you're not getting sick, and you're drinking beer every day. It's like the best thing ever. So I was sitting in the pub that's now called the Jon Snow, having a pint, thinking about the great work he did. 2 people walk in, and if you're English, you know how to spot Americans a long way off. And so 2 people walked in with a deep South accent, said, "Is this the pub where Jon Snow used to come?" And the guy said, "Yeah." And he goes, "Is that coat of arms a House Winterfell?" And the guy looked at them and said, "Get out." So hopefully some of you know the Game of Thrones. So, all right, so I'm going to talk about 4 different areas here, one of them being the patient, which is really a key area for us. So many systems and so much IT works around the patient, but it doesn't really connect to the patient. So here's a picture. This is our NICU here, and a lot of stuff. Right here's the patient, okay? So when we say the connected patient, is this really the connected patient? Well, no, it's not. The patient's obviously connected to a lot of things, but they're not connected to what's going on around them. And so we've spent a lot of time thinking about the patient in our hospital and how they get connected. The physicians are connected. They work with the EMR, the prescribing systems, ordering systems all day long. The nurses are all connected, but the patient themselves are not. So this number 125, that number 125 is the number of patients in our hospital today at Phoenix Children's that don't have any kind of connectivity. They don't have a tablet, they don't have a phone, they can't borrow a phone off anybody. They are sitting by themselves in that room with nothing to do. And some of the children that we take care of are in here for a couple of months at a time. A cystic fibrosis patient may have to go into isolation in the winter months and they can't talk or see anybody for months at a time. Now, I have a daughter, she's 13. If I took her device away, the world would end, right? Yeah, I know you probably, some of you now on your phone already, so this is a big thing. So we kind of asked ourselves, it's 2016, can we do better than having a TV up in the corner of the patient room showing Judge Judy or whatever it may be? We've got to be able to do something better than that to entertain the children. It's 2016, we can surely do better than rolling in a cart with a VCR player to play an educational tape, and we still did this until a few months ago. This is how we educated patients on their diseases, rolled a cart into the room, played a videotape. Family may want to watch it 2 or 3 times because it's a new disease, but we have to roll it out and take it to the next patient. So this is not good enough. There are systems out there that do kind of a more entertainment package for you, a more complete package, a little bit what you might see in a hotel. Problem is those systems cost $1 to $2 million a year. Okay? No reimbursement for that, that's just straight cost. It's just a computer at the end of the day. It's got to be easier to do than that. So what I like to do oftentimes is commit first and then try and figure it out later. It gives an extra little punch to trying to get something done. So I approached the Cox Family Foundation and we asked for a grant to try and figure this out. How are we going to get more connectivity for our patients? So I wrote a nice little PowerPoint, did the presentation. I hadn't really figured out how to do it. Surprise, surprise, they wrote me the check. I was like, oh my gosh, I got to do something now. So focus the mind, and what we came up with is effectively an iPad in every single patient room. Now that may sound easy. Why was that so hard? Well, the iPad can't get stolen. The iPad has to be charged at all times. The iPad has to be infection control worthy. These iPads go in the bed with the patient. You can imagine what else happens in the bed. Lots of nasty things happen in there. And we had to be able to control the iPad because there might be children of different ages in that room, and a 15-year-old kid may not be appropriate to see the same thing as a 3-year-old and vice versa. So we had to figure out how to do that. We had to get education there, all these different things. And so I actually have right here, after a year of work, we've now figured out how to do this. This case itself was sourced out of England. It's a 26 case we tried to use on this to pass infection control, pass drop tests, pass throwing across the room, all the things we had to come up with. And we have now a patent pending on the way we're going to do this work. But right now, the kids at the hospital have an iPad that they can use. And when they leave the room or they transfer, that iPad's white. Now, what's really important with that is they can let them do whatever they like on that iPad. So they can put in their Twitter account, their Facebook, their Instagram, whatever they want to do, they can do it. And the parent has control. So if mom says, I don't want my kid to have an iPad, one click on the web page, that iPad becomes a clock. Can't do anything else with it. Patient is a 3-year-old patient on a service for gastroenterology. We load up education material straight for GI. So a lot of work done on that to try and get the patient connected to the hospital. So 125 smiles is our goal at the end of that process. So let me show you one other thing. So that's great for the patients that are a little older, up about, can move around. What about the patients that we have in our neonatal intensive care unit? If you've ever been a parent of a child that was in the NICU, it's a very traumatic time. The first week's kind of okay. You spend a lot of time in the unit, take care of the child, and then life catches up with you, okay? And you can't be in the unit all the time because you've got other family members, you've got a job to do, and so you can't spend time in that neonatal intensive care unit. And those first few months, incredibly important bonding experience. So we tried to figure out how can we get past that? How can we allow the patient and the family to bond but not have to have them physically present? And this is what we came up with.
It was maybe 2 days after he was born, and Kyle had been up visiting him in the NICU, and I was still a patient here, and he came and said they're going to put a webcam on him for us to look at him any time of the day.
A baby cam is a camera that's placed over a giraffe bed or an isolette that allows parents and whoever they designate to view online the opportunity to view the baby 24/7.
It gave us a peace of mind just having the webcam to go and any access and look at him, just to see that he's a real baby and that he was breathing and sleeping.
I can't emphasize enough how useful and helpful it was to the entire family, especially since they were far away. For them to be able just to log in anytime and watch him and see him and watch us interact with him, they learned the care times. So they would log in to look at him at 2 and at 5 and at 8, and they could see us change him and that kind of stuff.
When we're doing any painful procedures such as an IV restart or blood, a heel stick, we gently put a nice little sign at the top of the isolate that says, I'll be back soon, I'm getting a procedure done, or oops, my IV's out, I need to get it restarted. Things of that sort.
The nurses in the NICU do a great job with the webcam because it's not something they've had around and it's not something that benefits them. It benefits the family and they do it for the family.
It doesn't change how I care for a baby, but as I put myself in that family's position, because now I'm a grandmother, and when I wouldn't be able to be at the bedside, would I want to see my grandchild, and what they're doing? Absolutely.
Is that wasn't actually at Phoenix Children's Hospital, that video. So I committed to do this, raise the money through a grant to get it, and then the company that made it went bankrupt. So I was like, great, I got to figure out that myself. So starting tomorrow, actually our system at Phoenix Children's goes live, and we have all 26 beds in our neonatal intensive care unit that you can log in and watch the patient on a phone, an iPad, any kind of device. And it's smart enough to know when the patient gets discharged or moved to cut that feed off, because we have HIPAA and things like that to deal with. So that is going live, and that's our connectivity to our intensive care unit patients. So this last slide, some of you may have seen this before. This is the heart of a child that we were doing cardio surgery on. And we actually 3D print this heart. So we do an MRI, we do a scan of the patient's heart, and then we 3D print it and we give it to the family. And so before we start surgery, we sit down with the family, with the surgeon, they explain what the procedure is going to be done, and we give that heart to the family, and it allows them to stay connected to what's going on with their child in a very, very scary time. So let's talk about efficiency a little bit. At Phoenix Children's, we're not like some of the other big children's hospitals around the country with a huge endowment, with all the money in the world to play with or whatever we want to do. We have some very real pressures here. 1.1 million children in the Phoenix metro area, so that's a lot of children to take care with. 60% of the patients we treat have no commercial insurance. That is a challenge for us. What that can mean in many cases is a $60 million shortfall every year just to treat those patients. We treat them without any kind of concern about their ability to pay. If they show up, we take care of them. Our payment model, many of you have heard about this in healthcare, is changing rapidly. We're moving away from a fee-for-service kind of model for being paid for actually taking care of a bundle of care for patients, and that's very difficult to kind of change our system on the fly for how we do work. And then obviously, in Phoenix here, there's a lot of consolidation of the healthcare industry and a huge amount of competition as well. And so all those factors play into our need to be efficient with the limited resources we have. And so PCH recently finished putting in a complete EMR in all of our hospitals with a single database. And many of you have worked with EMRs before. It's not the most favorite time for physicians. It doesn't seem to matter what system it is. They're not particularly happy, and it doesn't always make things better. So we spent a long time, because we couldn't afford to have a 6-month drop-off in the number of patients we saw while people got used to this system, which is the typical amount, by the way. Some hospitals, it's even a year before they get up to the normal volumes again. So we worked incredibly hard when we did this EMR implementation, did it over a 15-month period, 40 clinics. We had an optimization effort in that actually went in ahead of time, nothing to do with IT, trying to streamline their processes and standardize them in a kind of a lean methodology. And you can see there on the graph, we went in a September timeframe. You can see the number of patients they can see already started to increase. We implement the EMR, you see that drop going down. 3 weeks later, we're back up to full speed. I'm not seeing very impressive. That's pretty much unheard of, and we couldn't afford, both by seeing the patients and by loss of revenue, to do anything different. So we spent a lot less time focusing on the screens in the EMR and the technology, much more on the workflows and the processes. So how did we do it? Well, this is what the documentation system looked like out of the box. Not particularly easy to use. Tons and tons of checkboxes, 15 screens of things the physician had to fill out, when in the past they just had a piece of paper. We decided this wasn't good enough. We decided to pull out the documentation out of the EMR system we picked, not what a lot of people do, and switch it out with a web-based documentation system that was simple. It was HTML-based, allows the doctor or the nurse to click on the item as one click is true, one click is false. So if the patient has this, they click it once. If they don't have it, they click it twice. And it also then keeps this longitudinal record, because a lot of times with this documentation, we fill it out once, we never use the information again. We never know when they come in a second time that they had a headache the first time they came in. So this documentation automatically keeps track of that. So that was one way. So our physicians now can do their documentation quicker than when they were dictating it or they were doing it on paper. The second thing we did, we thought about this from a kind of a process perspective. What this picture is, if you can see it, imagine when you go into Wendy's or McDonald's, you put your ticket on there, and there's a little screen, and it kind of shows the tickets as they're working through the process all the way till you get your food. We kind of had the same idea. Well, as a patient moves through the process in our clinics, they're really going through different parts of the system, and we need to keep track of how many minutes they're spending in each different area. And if they're spending too many minutes, we need to kind of move that process along. So this is a complicated screen, but this is actually a plasma screen in every single clinic in the back of the office, and it allows people to see where a patient is in the process. And every box represents a patient. I've kind of grayed out the patient names. The big number there is how many minutes they've been in that phase of their treatment. And we can keep track of that. We can see how long they've been for their entire stay. And in fact, our residents will often look in that treatment section, and if they've been in there with a physician maybe 25 minutes or 50 minutes, they think that's too long, they'll go in there and they'll tap the other resident on the shoulder and say, I think we need to keep things moving. So they're kind of self-policing that and moving things through. So what's this? This is a waiting room with no patients in it. Not necessarily a good thing. And what we struggle with all the time at many hospitals is what we call the no-show rate. So we book patients, we fill the schedule, and then typically in a clinic, 10 to 20% of the patients don't show up for whatever reason. Especially in a hospital like ours where access and transport to the hospital can be a challenge for some people. Well, as you can imagine, that's a bunch of fixed costs sitting in that hospital now waiting to treat those patients that don't show up. So a 1% no-show rate for our hospital translates to $1 million of lost revenue. More importantly, it means that a patient that really needed to be seen couldn't be seen, and we were doing nothing at the same time. So we always try and think about what we can do to lower the no-show rate. So this is my slide, predictive analytics, big data. You think I'm really smart, put it up there. Thought, great, we can use predictive analytics and big data, and we're going to solve this no-show problem. We're going to take all of the data we have of all the no-shows, all the people that show up, all the demographic information, all our insurance information, and we're going to figure out and predict who's not going to show up tomorrow. And then what we're going to do is we're going to overbook those appointments with a standby appointment and potentially get people in. There's this great analysis, took a couple of months, loads of data, huge big data model, predictive analytics, everyone thought we were great. We came up, we figured out that we think with 90% accuracy, we can predict 20% of the patients that aren't going to show up. And so we started this model of predicting. We think this person's not going to show up. We think this person's not going to show up. Validate the model. Epic fail. Didn't work, okay? What turns out is our patients move around so much that their information changes, their insurance changes, all these factors that we think affect them showing up for clinic alter so much in a 3-month period as the model is invalidated almost as soon as it's built. So it didn't work at all. It was my great chance to use predictive analytics, didn't work. So we don't give up, we start again, and we reapproach the problem from a different perspective. And we think about, this is a picture, you may remember this from the, if you're a little old as I am, in the 90s, defragmenting your hard drive used to be a thing you were told to do all the time. So we took this concept of defragmenting the schedule. What happens with the schedule is we book everybody up, people cancel at different times, often 3 days before they cancel. We never fill the slot back. It's too difficult to fill the slot. We just book someone at the end. So the schedule ends up being incredibly defragmented. And we know this ahead of time. We know this a couple of days before. We just don't have the resources to call 15 people to hope that one of them will take the slot. So we figured it out ourselves. So we came up with a report that says, where are all the gaps in the schedule? Okay, get me all the gaps in the schedule for tomorrow, the next day, the day after that. Let's text the patient and say, we've got an opportunity for you to jump from 3 weeks from now to 2 days from now. Would you like it? Well, the patient's like, awesome. I'm jumping the queue. This is my Disney Fast Pass. I'm going to get here quicker than ever. We send them the text. They say yes. They click on the text. They come into the app. They validate who they say they are. And they then got a choice. They can say, yes, I want this new appointment. Or no, I don't. Stop bothering me. I'm happy with what I've got. We send that out to hundreds of people because we got lots of eligible people. Now the schedule starts to get filled up. Even better is all those people from 3 weeks out now get moved up to 2 days from now, and the end of the schedule starts to free up, and we can book people quicker, right? Much, much more successful in trying to predict when people aren't going to show up. Patients think it's great. They get an earlier appointment. We think it's great because the schedule gets filled. Last little piece on this is going to change everything. It's already starting to happen. is you know about urgent care. So a lot of people show up in an urgent care because they don't want to sit in our ED waiting room for 8 hours because it's busy. They go to urgent care, they get in an hour. Now you can do that stuff over the computer. More and more of these diagnoses can be done, and so companies like MD Live, who now have their brand much like Amazon, where you connect with them, rent a doctor on the back end, the doctor's sitting there somewhere in a white coat in the house and can get online and provide care. So this is completely changing the model. No need to even show up. No need for a canceled appointment because I didn't even make one to start with because I'm just going to connect on the computer on my phone when I need care. This model is coming. It will completely change how we do primary care. All right, so next thing is safety, patient safety. So this is really important to us to keep trying to improve safety. What we used to do is do 3-month retrospective chart reviews. So we would pull all the charts 3 months after something had happened, read through it all, try to figure out what we did wrong, and then do better next time. Well, the problem is that's 3 months late. The bad thing's already happened. That's not the best way to do patient safety. We want to do automatic, in-the-moment, real-time patient safety. And so what we're doing more and more is programming our processes to always be safe. And as an example here, I'll give you, patient comes in, doctor writes in the note that this patient should be on isolation. That means they have to have special precautions in their room, but the isolation order never gets written. Okay? So then we have a human that's reading through all the documentation in the ED every day, trying to figure out, should this patient be on isolation? Are they on isolation? Put them on isolation if they're not. We find 70% of the patient get onto isolation, 30% generally do not. In the first 36 hours, bad things can happen. Okay? These patients need to be in isolation. So we make a simple change. We allow, whenever they write the word isolation in the documentation, for it to pop up and say, would you like to put an isolation order in? Doctor says yes, everything happens. 100% compliance overnight, get rid of the person checking the chart, looking for isolation orders. That's kind of pre-programming that system to work. Another great example is hand hygiene. You may have heard of hand hygiene a long time. It's the simplest thing in the world. Every person should wash their hands when they come in contact with a patient, before and after. It's the number one problem. People just, a nurse that's dealing with 50 patients a day, that's 100 times a day, they have to wash their hands. It isn't always compliant. Thousands of tools to do this. What we used to do is paper forms. People would do an observation, turn it into the quality office. 3 months later, they would analyze it all, and you get the results 6 months later. No one can remember what I did anyway, right? Bad, not a good outcome. So we put that hand hygiene survey on a phone. We allowed the nurses to shop each other all day long. And we allowed them to go, when they do that survey and they do it in real time and they say, I saw you washing your hands, the nurse gets a thank you email back saying, great job, we caught you in the act of washing your hands. And then we report out all the time to the nurse managers how many observations were done every week in every unit. Are they keeping up with a quota of doing 100 observations a week in those areas, and where are they at with their compliance? Finally, we put it on a big plasma screen in the unit, so in the nurse's break room every single day, a green box means you did a good job, a red box means you could have done better next time. And so they see this in real time. It's not 3 months later, 6 months later, they're seeing it when it's happening. Another thing we did is physician order entry. Many of you have heard of that before. That's when the physicians are putting their orders in electronically. That's all great. We've been doing that for a really long time. What it doesn't do is stop you putting a bad order in. Okay, now you put an electronic order in, you don't necessarily put a good order in. And so a big part of that is dosage and medications, and especially in pediatrics, the range of medication or the dosage of medication you give can make a huge difference. We're all adults, we can absorb a big dosage. In children, based on their age and size, a dosage, whether you're twice the weight or half the weight, can make a huge difference. Intravenous potassium, for example, is what people are given often when they want to commit suicide or they want to kill themselves. So it's a very dangerous drug. We have to give it sometimes for different medical benefits. You can't get that dosage wrong. And that dosage is based on the weight and age of the child as well as the gender. Most EMRs don't have this system built in because for adults it's not necessary. And most EMR vendors aren't interested in pediatrics whatsoever because the market's so small. So we built our own dose range checking system. Well, we have thousands of drugs, okay? Old way is to write one at a time, build every single thing one at a time. It would take us 3 years of work every single day just to put it in. And I like to show this slide sometimes. This is the way we used to do it. Just because we've always done it that way doesn't make it a good idea, okay? If you ever tried running the bulls, it's not that great of a thing. So what we did was we figured out, first of all, how are we going to find out what the ranges should be for these drugs? We don't know. There's nothing published. Nothing says what the pediatric range for these drugs are. We had to figure it out ourselves. So we used data to do that. And we analyzed over 500,000 drugs, 500,000 orders over a 5-year period. And we figured out by frequency diagrams what the appropriate ranges were. And we figured out a kind of a safe range, what we call a soft stop, which is, hey, are you sure you want to do this? And a hard stop, which is you can't do this. Okay, figure that out. by data for all those thousands of drugs we had, figured out the kind of decision support protocol, because you can't just stop people ordering stuff. Occasionally, it's necessary to break those rules for the patient, and we can't stop that happening. So figured out this complicated decision support algorithm, programmed it into the computer in one shot, and made that thing go live. That was about a 3-month effort. So what did the results look like in the first 10 days? So here's some examples. 40 microkilograms ordered, submitted dose was 0.4. Reduction of 100 times overdose would have happened on this one example. Okay, this was being caught by the soft stops. Not the doctors did a bad job. Mistakes happen. Everyone's human. Okay, before this would have not been caught unless it was by the pharmacist. Now the computer's catching it. So a 2 to 100-fold reduction in dosage on a regular basis. In the first 4 months, 11 hard stops on that intravenous potassium. That could have been 11 really, really serious situations that were stopped simply by the computer being able to control it. Okay. Each month, 330 hard stops. That means that the call has to go from the pharmacist. The physician that gets a call from the pharmacist says, talk me through this. Why do you really need to do this? They talk about it. Some of them go through. It's appropriate. But as you can see here, 90% of them stop. That's a great win just by a little bit of computer programming. So last little piece on this. All that's good. We spend all these millions of dollars on these systems. If it's an Epic, it could be $100 million for the EMR. We aggregate all this clinical data together, and we think we're going to make smart decisions. And we have all this stuff in place, and we leave it. The last mile notification is a pop-up screen. How lame is a pop-up screen? I mean, is that all we can do? We spend all this money getting the information, figuring out it's wrong, and we deliver the message in a pop-up screen with a button that says, OK, cancel. That is terrible. So what we're trying to figure out is, what's a better way we can do this? How can we guarantee, hardwire, that when something goes wrong, we know it gets taken care of and we can validate it? And we have this concept called care co-pilots, which is almost like a physician and nurse sitting in a bunker watching all this thing going on and being on the shoulder of the real physician saying, you need to go to room 54 because we think something bad is likely to happen. The physician goes and sees the patient. They're the hero. That's the real person in the room. But with a camera in the room, we can validate the action actually happened. Okay? So we're exploring this whole concept of closing the loop, delivering the message in something other than a pop-up to make sure work happens. Right, last piece here, so research. So I saw the impressive presentations out there. You guys are pretty smart. I can't understand any of that stuff that's out there, but I do deal with research on a regular basis. And research for me in IT is a constant struggle because I live in an environment normally that's corporate IT. Our goal is to control the variables, least number of desktop configurations, standard environments, control with the least number of people possible, everything that can happen in the environment so we don't have bad things like ransomware happen to us. In a research environment, you want no controls. You're breaking all the rules. The whole DNA of a researcher that I've ever met is you break every rule that's ever there because you're trying to do new discoveries. So I have to come up with a research computing environment that allows all the rules to be broken, no shackles, because if I don't do it, they're going to do it anyway. You guys all know, right? You've got your Macs, you've got your root passwords, you go and install anything you like, you need something off the internet. That's no in corporate IT. So we always fight the struggle. But this was an interesting example I found. So you may not know this. So Netflix decided they were going to publish all their data from who'd watched their movies in a blinded way. So they just removed the individual person's identity who watched the movie. They put it out there. It's like, great, you can go mine this big data. Well, IMDb, which is another company that keeps track of movies, also decided to do the similar thing, and they blinded their data. Individually, those data sets were fine. Okay? Some smart kid, 15-year-olds, put the two data sets together, puts them together, figures out a person who's watched Brokeback Mountain, where they live, outs them, okay, in public, person sues Netflix for disclosure of information. Okay, so all the time I get asked, blind this data, just take out the patient name, leave the zip code, no one will ever know, I need to be able to use this data for research. The reality is when you lump multiple data sets together, bad things can happen, and we can't always do that. That's a bad thing for research. So how do we solve that? We have this concept of synthetic data. So don't blind the data, okay? Because you can always sometimes reverse engineer that. Take that data, take that huge data set, and engineer a complete synthetic data set from it that has all the same statistical properties, but is completely random and made up, okay? Then you have all the same ability to do research. And so when we've done this, and we've worked with a company called MD Clone, we can produce statistically the exact same data set. But now it is all completely fake data. We can post it out on the internet. We're not breaking anyone's confidence. And we are convinced that this is the way to go forward to share information. The reason it's so important is around genetics and the work we're doing with genetic testing. So genomic research, often everyone thinks about the sequencing, the DNA test, the fancy machine we put it in that builds out the DNA. I would suggest to you that that's not what it's all about. And this is going to be hard to read, but the sequencer is really the first start of the process. After they're sequenced, you get 3 billion base pairs in this BAM file, which is a huge computer file. It means nothing to anybody, right? Then you have to put it through a huge amount of processing that turns it out at the end of the day to a report that somebody can actually read and say, this may be 3 of 70 things that might be wrong from a genetic test. Okay, still not very useful because we don't know what the things mean. So with the gene, you all know this probably a lot more than I, but in the genome, there's much of it we don't understand at all yet because we haven't inferred what it means. So what's really important is taking that full genome data that says this is how these people are, bumping it up against the clinical data that says the same person had these clinical characteristics, bumping it up against science and nature and articles out there that people are figuring things out and coming up with new discoveries. Okay, and those new discoveries will then lead us to find drugs that can cure the problem. So for us, producing this data, getting this clinical data on all the patients we're doing genomic testing and allowing it to go out into the community to allow the kind of crowd-funded the research and have lots and lots of people crunch the data and find these connections between the genome and the clinical data is incredibly important. We can't do that under the HIPAA laws. Okay, so we're finding this synthetic way to do it. Now the problem with this as well is one genome is going to produce for us about 2 terabytes of data. In a corporate environment, if I stored 40 genomes, I'm spending $1 million on an EMC SAN, which is the disk storage that it puts on. I can't afford $1 million for all 40 patients that we test. We have to find a cheaper and better way to do it. And of course, the EMC, the SAN vendors really want to do that, but we've had to find a different way around it. And the way we did it, how cheap can we get 480 terabytes of data? That's a lot of data. We found a company that does something like Dropbox. They white labeled or outsourced their software to us. They gave all of their knowledge to us for free. We basically created a Dropbox type environment. Instead of spending $1 million on the storage for this genomes, we did it for $20,000. Right? Deep freeze storage. Now, you wouldn't want to run your EMR on this storage. It's very slow. But if you imagine for these genomes, we're storing them and we're not touching them for a long period of time. So we're having to invent new things with new ways of doing things from other parts of industry just to try and support these brand new technologies like genomics. So I'm going to finish up here. Why is this all important? At the end of the day, what does it matter? And every single important meeting we have at Phoenix Children's, we end with a patient story. Because this, at the end of the day, after everything else, is what's important. So I'm going to end with a patient story, and thank you very much for listening.
My name is Hope. I am 14.
In November of 2013, Hope was sent home from school a couple of times with a fever. We thought it would be the flu. We were waiting for all the other flu symptoms that never came. Took her to our pediatrician. He was a little worried. He had seen some meningitis in the area and that we should go to a hospital. So we were admitted in that hospital just prior to Thanksgiving. By Thursday, the morning of Thanksgiving, I became insistent that we be transferred to Phoenix Children's Hospital. And then it was the next day, that Friday night, when Hope and I were in the room, that Hope had her stroke. She was just looking at me and she looked confused. And then that look became a look of terror. And right in front of me, Hope had a massive stroke as she sat herself into bed. She was trying to speak to me. She was trying to form a word. And the words were not coming out of her mouth. Looking into your daughter's eyes and being so close, and the lights are going out, and not knowing why. And it's a terrifying journey for any parent. I don't think anybody was looking for a perfectly healthy girl with a little fever to come down with a stroke. And unfortunately, not a little stroke, but a massive stroke. Hope's stroke affected the left side of her brain and the frontal lobe. So speech and language were absolutely wiped out. They were very realistic in the hospital with us when she had her stroke. It was well within the realm of reason for them to tell us that I would never have a conversation with her ever again. And that is a proper diagnosis. she heard it. And she began to prove them wrong. She's proven to be a fighter. She has yet to complain. She hasn't even slightly given up. Your donations matter.
I am very good.
But thank you very much. Appreciate the time.